So let me express my gratitude to Georgina and my privilege to introduce her. Georgina and I we know each other quite a long time, since quite a long time. Yesterday, we discussed before entering on stage. And Georgina is the reference for pediatric hepatology. Georgina is professor of pediatric hepatology at King's College School of Medicine in London, and she contributed some pivotal work since the very beginning of pediatric hepatology. Georgina was kind enough to accept our invitation, and we are eager to listen to her wisdom, guiding us across the juvenile autoimmune liver disease. Georgina, thank you.
Thank you very much, Claudio. Thank you for this invitation. I'm extremely privileged to be here and giving this webinar. As you know, juvenile autoimmune liver disease is very dear to my heart and it's my main interest. Autoimmune hepatitis is the prototype of autoimmune liver disease, and it is a progressive inflammatory disorder of the liver with a biochemistry which reflects hepatocellular damage with high transaminase, often prolonged INR. It is characterized by positive autoantibodies and high levels of immunoglobulin G, and histologically by a dense portal tract infiltrate by lymphocytes and plasma cells, which invade the surrounding parenchyma into what is called interface hepatitis and lead to hepatocyte damage. Obviously, it's also a diagnosis of exclusion. It is important to exclude other pathologies that may mimic autoimmune hepatitis, and these include, particularly in the juvenile form, Wilson disease, and then hepatitis C, hepatitis B, hepatitis E, very important, and MASH, so the metabolic associated steatohepatitis. Type 1 autoimmune hepatitis is characterized by the presence of anti-nuclear antibodies or anti-smooth muscle antibodies, and is typical of adults and children. I mean, it can affect both adults and children. While type 2 autoimmune hepatitis is characterized by the presence of anti-liver kidney microsomal type 1 antibody or anti-liver cytotoxic type 1 antibody, and affect mainly children and adolescents. Another important autoantibody in autoimmune is anti-SLA, anti-soluble liver antigen. This autoantibody is more specific for autoimmune hepatitis and in general for juvenile autoimmune liver disease and autoimmune liver disease. Is present in all forms of juvenile autoimmune liver disease, but is not detectable by immunofluorescence. So you need to ask for it specifically. Usually it's detected by ELISA. If they will not give you the result, if you just ask for immunofluorescence for autoantibody in liver disease. It's associated with a more severe disease, and also originally when it was described, it was suggested that it may represent a third type of autoimmune hepatitis, which is negative for all the other autoantibodies. However, this has been discussed a lot, and it may not be the case. Certainly it's present in all types of juvenile autoimmune liver disease. The presentation of autoimmune hepatitis in adults is often chronic with mild to moderate severity. Although I have to say that more recently, also in adults, very few presentations are reported. But in children and young adults, the presentation is often acute and pretty aggressive, actually very aggressive. In the juvenile form of autoimmune hepatitis, 2/3 are type 1 and 1/3 is type 2. There are similarities between type 1 and type 2 autoimmune hepatitis. There is a female preponderance. There is an association with other autoimmune disorders, for example, thyroiditis, diabetes, and so on, in 20% of the patients, and the family history of autoimmune disease in about 40% of the patients. High IgG are present in about 80% of cases. I insist that it's very high, the proportion, but even if you don't have high IgG, you can't exclude autoimmune hepatitis. There are differences between type 1 and type 2 autoimmune hepatitis because type 2, the LKM positive disease, presents at a younger age, even in infants actually, with partial IgA deficiency, and less frequently with cirrhosis, and more frequently with acute hepatic failure. There's a more acutely presenting disease. Now, long time ago, we realized that about 50% of children or adolescents who present with a serology of autoimmune hepatitis type 1 and a histology similar to autoimmune hepatitis type 1 have an overlap syndrome with sclerosing cholangitis. And we call this condition autoimmune sclerosing cholangitis. So the juvenile form of autoimmune liver disease comprises not only autoimmune hepatitis, but also autoimmune sclerosing cholangitis. The diagnosis of autoimmune sclerosing cholangitis is that of high IgG, presence of autoantibodies, and usually anti-nuclear antibody, anti-smooth muscle antibody, a liver histology with interface hepatitis, as I described before. But then if you do a cholangiogram at presentation, you can find abnormal bile ducts. This is an ERCP in one of the first cases we described, and you can see very abnormal intrahepatic bile ducts all over in the liver. Despite this histology, I would like to stress, where you really would not diagnose a sclerosing cholangitis. Autoimmune sclerosing cholangitis is different from autoimmune hepatitis type 1 because it affects equally males and females. Another important point is that the gamma GT and alkaline phosphatase levels are often normal at presentation. They often have very high levels of IgG. They are frequently positive for ANCA, anti-nuclear cytoplasmic antibody, and the condition is frequently associated with inflammatory bowel disease. However, it is important to stress that this inflammatory bowel disease may be completely asymptomatic. So in practice in our unit, that when we diagnose a child with autoimmune liver disease, we always perform a colonoscopy to see whether or not there is inflammatory bowel disease. And we have seen children completely asymptomatic with quite severe ulcerative colitis. How do we make a diagnosis of autoimmune hepatitis? This seems to be a very simple thing, but is not. And this has puzzled the adult hepatologists and, of course, the pediatric hepatologists. We go back to 1999, when the International Autoimmune Hepatitis Group published this diagnostic criteria for the diagnosis of autoimmune hepatitis. This was mainly done to be sure that in the various series published, the patients all had the same condition. However, these diagnostic criteria are extremely cumbersome and very difficult really to apply if you want to use it in the clinical setting. For this reason, there was a publication of the simplified International Autoimmune Hepatitis Group criteria in 2008, which are very simple and you can use it very simply at the bedside, but they are much less sensitive and specific than the original International Autoimmune Hepatitis score, particularly when the patient presents acutely, and neither the original nor the simplified IHSG scores allow the differentiation between autoimmune hepatitis and autoimmune sclerosing cholangitis. For this reason, the ESPGHAN has published a position paper for the diagnosis of juvenile autoimmune disease, with scoring system and scoring criteria. And you can see immediately that the titer of the autoantibodies, which are considered positive in children, is much, much lower than the one in adults. This because normal children, we're showing it very clearly, do not have autoantibodies, and therefore even low titers are quite important. But the other even more important thing is that we do perform a cholangiography presentation, and if that is normal, we diagnose autoimmune hepatitis, and if that is abnormal, we diagnose autoimmune sclerosing cholangitis. And that is the scoring system we now use. What about treatment? We treat autoimmune hepatitis and autoimmune sclerosing cholangitis in the same way as presentation, and we want to achieve remission. What is remission? In adults, remission is considered when you achieve normal transaminase levels and normal IgG levels. But in children, we are much, much more demanding. What we want also, not only normal transaminase levels, normal IgG levels, we want negative or very, very low titer, less than 120 ANA and SNA, or negative anti-liver killing macrosomal antibodies. If the antibodies are not negative or really almost negative, then the child is not in remission. The standard treatment for all presentations is of prednisolone and azacitidine plus minus azathioprine, and this really includes all presentations, including acute liver failure with no or less than grade 2 encephalopathy. If the patient presents with more than grade 2 encephalopathy with fulminant liver failure, usually they do not respond. It's worthwhile trying, but do not respond to treatment, and they require transplantation. A very important point to remember is that azathioprine can be hepatotoxic. Therefore, it's not advisable to use it as first-line treatment in ill jaundice patients, particularly if cirrhotic. And in fact, also for the adults now, the European guidelines, the EASL guidelines, do say very clearly not to start azathioprine at the beginning, but only 2 to 3 weeks after starting prednisolone. What we do in the juvenile form, we give 2 milligrams per kilogram per day of prednisolone with a maximum dose of 60 milligrams per day. And then the whole secret is, this is the most important message of this webinar, I think, is that once you start with that, which is pretty high dose, but then you decrease it gradually but quickly over 4 to 8 weeks to a very, very low dose of prednisolone, 2.5 milligrams per day, depending on age. Now, and weight, of course. Now, why you can do that? Because they present acutely with children and they usually respond very swiftly. But also, it's important to decrease the dose quickly because you don't want steroid side effects and you do not want non-compliance to the treatment. Of course, if a girl who is 15 becomes really Cushingoid, she will never continue to take her medicine. What we do is to try to avoid the side effects of steroids by decreasing very quickly the dose. If the child has also autoimmune sclerosing cholangitis, then we add also the ursodeoxycholic acid at a maximum dose of 15 milligrams per kilogram per day. Though I have to say that nobody has really shown that also the ursodeoxycholic acid really makes a difference in these children. There is no study, no control study showing that. A very important point is that you need to achieve the remission that I told you without side effects. You need what we call fine-tuning. You need really to follow the patient up very closely at the beginning of treatment. So what we do with our patients, we do weekly and sometimes twice per week liver function test, INR and food count, and modify the treatment according to the results. And the aim is not to achieve completely normal transaminase levels, but we want to achieve at least 80% decrease of transaminase levels within 6 weeks, which usually means that you will achieve full remission by 3 months, 6 months, and then 1 year. The azathioprine we add only if and when needed. What I mean with that? If you decrease the steroids so quickly, it may happen that the transaminase starts going up or stop coming down. So if really they stop coming down or they start going up a bit, then we add azathioprine at a very low dose, because azathioprine can be toxic, at 0.5 milligrams per kilogram per day, that we then increase it to usually a maximum of 2 milligrams per kilogram per day weekly, 2.5 in certain cases. You might ask me how many children who do need azathioprine, and in fact, ultimately, about 80% of the case need azathioprine. But this is important because they achieve a maintenance with a very low dose of steroids and azathioprine with really no side effects, particularly no physical side effects, which would affect compliance. What we do if you think of stopping treatment. Now, of course, the first thing the parents and the older children will ask you, how long do I have to be treated? And this is a difficult question to answer because the majority of children, in fact, probably need to be treated for a very, very long time, if not lifelong. However, what we do, we give daily treatment for at least 3 years, and this is very important as well, daily treatment, not alternate day steroids. We have shown very clearly and published that daily treatment with very low dose of steroids plus minus azathioprine does not affect the growth of the child. And we do give daily treatment for at least 3 years. Then we wait for a further year of completely normal transaminases in IgG levels and negative or low titer of antibodies checked every 3 months. And then we always perform a liver biopsy before stopping treatment, because we want to see there is no inflammation on the liver biopsy. I do realize that somebody suggested we do not need a liver biopsy. We do find that it's very important. And then we gradually discontinue the azathioprine and then prednisolone. And of course, when you discontinue, you need to follow up the patient really, really closely again to see whether there is a relapse. We never do this just before or during puberty, because we have, in our own experience, we have observed that there is a high rate of relapse just before or during puberty. Now, this is difficult to explain, maybe hormonal changes, or maybe it is because the children, when they are in puberty, they stop taking the medicines and they're not compliant, and this is quite possible. In adults, it has been published that you can maintain sustained remission on azathioprine monotherapy. This was a very old paper. And in children, this has been done in autoimmune hepatitis type 1 with success, and less successful in autoimmune hepatitis type 2. However, in my own mind, I cannot understand the rationale of this study. In fact, I prefer, and I would like to say that now also in the adult hepatology is saying, to use very minimal dose of non-toxic steroids and azathioprine, which keep remission, then having to increase the dose of azathioprine on its own to maintain remission. And azathioprine is certainly more toxic than very low dose steroids. There have been suggested alternative treatments for autoimmune hepatitis. This is for induction of remission or for difficult to treat patients. For induction of remission, usually they've been searched, these alternative treatments, because people don't treat them appropriately. They use high dose steroids for a long time, and therefore they have a lot of side effects. And because of this, alternative treatments have been sought. For induction of remission, there is a study, now in 1999, with some follow-up, with cyclosporine A, 6 months cyclosporine A priming in autoimmune hepatitis type 1, followed by prednisolone plus azathioprine in an uncontrolled study. The benefits are really unclear. The advantage is not to have steroid side effects, obviously high-dose steroid side effects. And the disadvantages is that 1 year remission was 78% versus 94% with prednisone and azathioprine. That prednisone and azathioprine then maintenance was in all patients, while we know some patients don't need azathioprine. Of course, we don't know also the long-term side effects of cyclosporine treatment because the in fact blood levels were kept pretty high, around 200. But the most important disadvantage of this study, which actually was not the intention of the author, has been the indiscriminate use of cyclosporine. So there are centers that have stopped using steroids and azathioprine and treat children with steroids and cyclosporine A, which is obviously much more toxic than azathioprine. And really the results are not better. Then there is a study which I need to mention, budesonide, because I see more and more often children treated with budesonide. So I need to say a few words about the study for induction of remission. This was a European multi-center study the use of this drug, which has a hepatic first pass clearance of more than 90% of the oral dose, and is said to have less side effects than prednisone. However, it cannot be used in cirrhotic patients. In this multi-center study, azathioprine was given 1 to 2 milligrams per kilogram plus budesonide 3 milligrams 3 times a day, which was decreased upon response. And the control group was given prednisone 40 milligrams once daily, which surprisingly, if you want, was reduced per protocol, irrespective of response. Then after this was happening for 6 months, and then budesonide was given to all patients for further 6 months. If you look at the results, the definition of response was a normal transaminase level without steroid side effects, which is a little bit biased towards obviously budesonide because budesonide theoretically should have less steroid side effects. And if you look at the overall results, they look very promising because the budesonide arm had 60% remission and the prednisone arm had 40% remission. So simply the better budesonide. Don't forget that these were also without serious side effects. But if we look at the pediatric group of this study, there were 46 patients between 10 and 18 years, and you look complete response at 6 months. In the budesonide was 16%, in the prednisone 15%, identical, and at 12 months was 50% in budesonide and 42% in prednisone, again identical. And this is compared to a 90% response, complete response, with the Espion protocol. Therefore, I think that at the dose used in adults, budesonide really does not work, and appropriate trials are needed. For difficult to treat patients who are resistant or unresponsive to standard treatment, MMF is the first line drug to use, mycophenolate mofetil. This drug is more effective in patients who are intolerant of azathioprine than unresponsive to azathioprine, and is more effective in autoimmune hepatitis than autoimmune sclerosing cholangitis. Other drugs, a very important point is that MMF is teratogenic, very teratogenic. So it is a drug which is quite difficult to give to girls who are possibly can become pregnant. So it's very, very important to advise them and to take precaution. Other drugs which have been used in pediatric setting are calcineurin inhibitors, as I said, rituximab and anti-TNF-alpha, and all these really have been used in very, very, very small groups of patients with limited experience. Also, tacrolimus has been used with very limited experience. What is the prognosis of autoimmune hepatitis and what is the prognosis of autoimmune sclerosing cholangitis? We started in 1984 a prospective study to compare these two conditions, and they were in 55 patients were recruited between 1984 and 1997, and 54 are followed up to date. One was lost to follow-up. And you can see the remission rate using the King's protocols for prednisone plus minus azathioprine achieved complete remission in the same proportion of children in the three groups. Juvenile hepatitis type 1, autoimmune hepatitis type 2, and autoimmune sclerosing cholangitis. The relapse rate was also very similar, and usually at the time of puberty. And we were able to stop treatment successfully in 19% of the autoimmune hepatitis type 1 patients, in none of the autoimmune hepatitis 2 patients in this study, and in 5% of the autoimmune sclerosing cholangitis patients. The transplant rate was 6% in autoimmune hepatitis 1, 14% in autoimmune hepatitis 2. Don't forget that autoimmune hepatitis 2 can present with fulminant hepatitis more often, before the children can be transplanted at presentation, and 27% in autoimmune sclerosing cholangitis. So it was definitely higher for autoimmune sclerosing cholangitis. The recurrence post-transplant in this study was incredible in the way that none of the children with autoimmune hepatitis type 1 or type 2 had a recurrence of the disease post-transplant, but 71% of the sclerosing cholangitis did. So it is not surprising to see that there is something very different between the two conditions. Another puzzling thing we noticed in the study is that you can have a completely normal cholangiogram at presentation and be diagnosed with autoimmune hepatitis, but then during follow-up and despite treatment, you can develop sclerosing cholangitis. Sorry, I do hear somebody speaking, so somebody is not muted. Okay. So 8 years later, a frank sclerosing cholangitis. And indeed,
un articolo scritto da Simona Gatti, amica tua.
Ma il giornale era questo?
and indeed,
Dr. Alerio, your mic is not muted. Please do it.
okay. Two further cases of autoimmune hepatitis during this prospective study, in fact, have evolved from autoimmune hepatitis to autoimmune sclerosing cholangitis 13 and 14 years after diagnosis. So it is not surprising that the transplant-free survival was significantly lower in autoimmune sclerosing cholangitis than in autoimmune hepatitis. To see whether we do a little bit better more recently, we have done a further study in 83 patients who were recruited between 2000 and 2004. And 54 had autoimmune hepatitis and 29 autoimmune sclerosing cholangitis. But you can see here, with a follow-up of 14.5 years, you can see that the transplant-free survival is very similar to the one before, and it's certainly worse in sclerosing cholangitis than autoimmune hepatitis. We had 11 patients who required transplantation, 5 autoimmune hepatitis, 6 autoimmune sclerosing cholangitis, and the recurrence post-transplant was 0 for autoimmune hepatitis, but was 2 of 6 autoimmune sclerosing cholangitis, so 33%. Better than in the first study, but still very high. We also noticed, and I think I'm pretty convinced about this, although it's very difficult to do statistical analysis, but that the progression of liver disease and the recurrence post-transplant are associated to the activity of inflammatory bowel disease. So it is very important to maintain the inflammatory bowel disease completely controlled if you don't want to have progression of liver disease. And of course, after transplant, if you don't want to have a recurrence of autoimmune sclerosing cholangitis. What we do now to treat these patients with severe IBD is to use anti-TNF-alpha. As you know, anti-TNF-alpha was said to be dangerous in liver disease because it can induce an autoimmune hepatitis type of disease. However, we did use it in 11 patients, 2 autoimmune hepatitis and 9 autoimmune sclerosing cholangitis with very severe inflammatory bowel disease, and we found the benefit in all of them, both the inflammatory bowel disease and the liver function improved in all, and there was no deterioration of the liver disease. What about the negative autoimmune hepatitis? Now, this is something that has become more fashionable more recently. Is it a type 3 autoimmune hepatitis? Does it exist really? Certain centers do describe it and insist that it does exist. We think that it is rare, but it does exist. It's rare if the autoantibodies are measured correctly and serially. This is an important point. If you send your autoantibody testing to a laboratory that tests the antibodies only for adults, or mainly for adults, they may not give you the lower titers for positivity that are important in the pediatric context. Also, the autoantibodies need to be done by people who are experts in doing autoantibodies, and they should still be done by immunofluorescence, not for anti-SLA, but for the others, because it is a more sensitive technique. And also they should be done serially, because we observe, and not only we, but several people have observed, the autoimmune hepatitis or autoimmune sclerosing cholangitis present very acutely. Often the autoantibodies are negative, and they become positive during treatment while the disease becomes less acute, possibly because the autoantibodies are in immune complexes at the time of very acute presentation. Negative autoimmune hepatitis is in fact very often associated to extra hepatic conditions, for example, aplastic anemia. And this has been shown by Major et al., but also in other papers. And more recently, it has been very clearly associated that negative autoimmune hepatitis is associated or may be associated to inborn error of the immunity, either primary immune deficiency, primary immune regulatory disorders, and autoinflammatory disorders. This is something pretty new. In primary immune deficiency, something which is not new is that anti-AKM positive autoimmune hepatitis can be associated with autoimmune polyendocrineopathy candidiasis ectodermal dystrophy, APSED syndrome, which is a primary immune deficiency very well described. But more recently, it has been shown that can be associated AKM positive autoimmune hepatitis to autosomal dominant signal transducer and activator of transcription 1, STAT1 gain of function defect, or variants in tumor necrosis factor alpha-induced protein 3. Some of these data are still in press. So I hope I have convinced you that in the juvenile setting, but I also believe that these things are also true for the adults, autoimmune sclerosing cholangitis is as prevalent as autoimmune hepatitis, at least in children and adolescents. However, if you don't do a cholangiography, you don't diagnose it. So cholangiography is needed for the diagnosis as soon as possible after presentation. The parenchymal response to immune suppression is similar to autoimmune hepatitis, but the bile duct damage in autoimmune sclerosing cholangitis can progress despite treatment. Autoimmune hepatitis can evolve to autoimmune sclerosing cholangitis. The evolution is not common, but it may occur during treatment and in the absence of histological features of sclerosing cholangitis. And if an autoimmune hepatitis is seronegative or unresponsive to treatment, think for inborn error of immunity and look for them, because I think that quite a number of patients with this condition, so seronegative disease or disease that doesn't respond well to treatment, might very well have an inborn error or immunity, which need to be treated in a different way. Thank you for listening to me. I just wanted to point out that the autoimmune liver disease group was established within King's College Hospital in the liver center headed by Alex Mowat in 1978. Diego and I, my husband, who is a researcher, and I joined Alex in 1977, and by 1978, we established the autoimmune liver disease group that is still pretty active today. Thank you very much.
Thank you very much, Giorgina, for this excellent presentation, full of good science and absolutely outstanding clinical wisdom.